Infective endocarditis for medical student. Infective endocarditis is a serious infection of endocardium, which is the inner layer of the heart chambers and valves. It is typically caused by bacteria entering the bloodstream and attaching to the damaged area of the valve. Bacteria usually enter the bloodstream through activities like dental procedures, surgery, or infections elsewhere in the body. If the heart was damaged, areas such as from the congenital heart defects, valve disease, or previous episodes of endocarditis, the bacteria can attach to these sites easily. Most cases are caused by bacteria, with Streptococcus and Staphylococcus species being the common culprits. In some cases, fungi or other microorganisms may be responsible. Symptoms can be subtle or severe, including fever, chill, fatigue, and muscle aches. Patient may experience heart murmurs, changes in the existing murmurs, or signs of heart failure. Diagnosis involves blood culture to identify causative microorganism. Endocarditis, that is the ultrasound of the heart, is crucial to visualize the heart valve abnormalities and assess the extent of the infection. Now there is a modified Duke criteria in which it is divided into three parts. The pathological criteria, that is positive histology or culture from pathological material obtained at biopsy or cardiac surgery. The major criteria includes two positive blood cultures with typical organism, or persistent bacteremia, or positive serology for Coxiella, or positive endocardiogram, whether it is vegetative or abscess or new regurgitation or dehiscence of prosthetic valves. The minor criteria includes predisposing heart disease or IV drug abuse, fever more than 38%, immunological phenomena, vascular phenomena, and microbiological evidence not fitting the major criteria. Antibiotics are the mainstay of the treatment, and the choice depends on the identified pathogens. Some cases may require surgical intervention to repair or replace damaged valves. If untreated, infective endocarditis can lead to serious complications such as heart valve damage, heart failure, or emboli, that is, clumps of infected material that can travel to other parts of the body. Prophylactic antibiotics are sometimes given before certain medical procedures to prevent bacterial entry into the bloodstream in individuals at high risk. Maintaining good oral hygiene is important, as oral bacteria can be a source of infection. Managing and treating conditions that can lead to endocarditis, such as valvular heart disease, is crucial. Endocarditis is a complex condition requiring prompt diagnosis and appropriate treatment. If we suspect infectious endocarditis, and if there is a low initial patient risk and low clinical suspicious, we initiate it by doing transthoracic echocardiography. And if it shows negative result and there is low suspicion persists, we look for other sources. And if increased suspicious during the clinical course, we often go to transesophageal echocardiography. And if the initial echocardiography is positive, then we weigh it as high risk echo features versus no high risk echo features. If there is a high risk echo features, we move on to transesophageal echocardiography. If there is no high risk echo features, no transesophageal echography unless clinical status suggests deteriorations. If there is a high initial patient risk, moderate to high clinical suspicious, or difficult imaging candidate, we initiate transesophageal echocardiography straight away. And if it is a positive, then we have to follow up with transesophageal echocardiography or transthoracic echocardiography to reassess vegetations as well as complication and treatment response as clinical indicated. Thank you.